Good morning, everybody. Very happy to be with you all today in these turbulent times, and really thrilled to have two phenomenal speakers from psychiatry to give us really practical skills to help us take care of our patients living with HIV. We're really lucky to have first Dr. Billy Smith, who is an assistant professor of psychiatry, who has specialty training, did a fellowship in geropsychiatry, as well as LGBTQ health, specialized training in residency. And he'll talk with us about antipsychotics. And then he'll be followed by Pierre Crouch, who's a psychiatric nurse practitioner, beloved by all, as he's been spending time at Ward 86 through his role at AHP. He's also board certified in addiction medicine and was a prior provider on the addiction care team. So we love to utilize his wealth of knowledge in both addiction medicine and psychiatry. Without further ado, I will remind you all to log in to PLWH /HIVGR to participate in audience response and turn it over to Dr. Smith.
Oh, in between, not at the end. Okay, sounds good. Good morning, everyone. It's great to be with you all again. I always love coming and chatting with you all. So this morning, I'm going to be talking about specifically antipsychotic use in bipolar disorder this morning. And my goal today is to really give you a nuts and bolts kind of talk where you feel empowered to use some of these medications in your own practice with your patient. So I have no disclosures to report. And so the objective today, I just have two in this short talk to describe the clinical features of bipolar disorder and then understand the role of antipsychotics in the management of bipolar disorder. And it sounds like we're going to take questions at the end. So I'll hold any questions till the end. Hopefully we'll have about 10 minutes or so. So we're going to start with a case to kind of frame this discussion this morning. So this is a 45-year-old man. He's got a history of HIV, bipolar disorder, and prior psychiatric hospitalizations, I think about 2 to 3 for mania and meth-induced psychosis, who's presenting to the clinic in a stable state to manage his psychiatric symptom. He stated that his last episode of mania was about 6 months ago. He was actually admitted to the unit that I work on 7B at the General with symptoms of decreased sleep, euphoria, grandiosity with delusional thought content around believing that he was like the next messiah. He had really rapid speech and impulsivity. He was gambling, which is not typical for him. He spent over $6,000, which is a lot of money for anyone, but particularly a lot of money for him. He reports that he really wants to take control and manage his bipolar disorder moving forward and prevent any further episodes of mania. And he says that predominantly he has manic episodes. He does feel depressed from time to time, but his most challenging aspect of the illness is his mania. He is stable right now. He's taken Zyprexa or olanzapine, 20 milligrams at bedtime. However, he's noted that he's gained a ton of weight, about 30 pounds since initiating this medication, and he's hoping to switch to a different medication that has lower risk of weight gain. So I thought it would be helpful to spend a few moments just going over the DSM criteria for bipolar disorder. A lot of folks get labeled as having bipolar disorder when they don't really have bipolar disorder. And it's particularly common in our folks who use stimulants because the symptoms of stimulant use can overlap quite a bit with bipolar disorder. And so I think it's important to tease this out a bit. So I'm hoping to empower all of you to make these diagnoses in your clinics. I know it's hard to access us in psychiatry at times. So the DSM criteria for bipolar 1 disorder, you need to have at least one lifetime episode of mania. And this diagnosis does not require folks to have an episode of depression. So there are plenty of folks who just have bipolar disorder who cycle through manic episodes, but then return to euthymia and then have another manic episode. The important caveat here is that it cannot be due to substances or another psychotic disorder. Commonly, we think of schizoaffective disorder, bipolar type. And we need to have at least distinct episodes lasting at least 1 week in duration. However, if someone's admitted with the severity of their manic symptoms, that automatically qualifies them for a diagnosis of bipolar 1 disorder. And so these are the symptoms below here. You need at least 3 or more of these symptoms. If the primary mood disturbance is irritability, which is a little less common than euphoria, then you need 4 of these symptom categories. And I'm not going to go through each one of these for the sake of time, but just to kind of refresh your memory around the diagnosis. And then we have bipolar II disorder, and this is actually a bit harder to catch in clinical practice. You need to have at least 1 episode of hypomania and then 1 episode of a major depressive disorder episode. Hypomania is defined as the same symptom burden of mania, but it's lasting less duration. It tends to be a little less severe, so somewhere between 4 days and less than 7 days. You cannot have any psychotic symptoms. So if you have delusions or hallucinations, you automatically get qualified for bipolar I disorder. And the majority of the time is spent in depressive episodes. And this is why it's that kind of a tricky population, because these folks often get labeled as treatment-resistant depression, when really they have bipolar II disorder, and we're just using the wrong medication to manage the depressive episodes. So if you're having someone who's really struggling with the depression, it's worthwhile to do a good screen of any prior hypomanic episode, because you might just be using the wrong medication to manage them. And so thinking back to our case, does our patient meet criteria? He had decreased need for sleep, grandiosity, impulsivity, fast speech, rapid thoughts, and he was hospitalized. So therefore, he does meet criteria for bipolar I disorder. However, it would be very prudent to make sure that he wasn't using methamphetamine during the weeks prior to his hospitalization, because that may be more related to a stimulant use. For him, he did have very clear episodes of mania, not due to substances. So now time for our audience response questions. So the first question is, what are the role of antipsychotics in the management of bipolar disorder? Treatment of acute mania only, indicated for both bipolar depression and mania, only indicated for the management of mania, and only indicated in when psychosis is present with a manic episode. I'll give you a few moments. I can't see the responses coming in, so okay, cool. Okay, and I think that's probably enough time. So B indicated for bipolar depression and mania, and C only indicated for the management of mania, the 2 most popular. And the correct answer is B, indicated for both bipolar depression and mania. So these are really effective agents to use for both aspects of the illnesses, and I'll obviously get into that in just a moment. Our next question to follow up on that is, which antipsychotic is FDA approved for bipolar mania and depression? So it has an FDA approval for these indications. Olanzapine, aripiprazole, also Abilify, cariprazine, also known as Vraylar, quetiapine, also known as Seroquel, both olanzapine and aripiprazole, or both cariprazine and quetiapine. Okay, that was the requisite amount of time. So a little bit more of a spread here. We got Zyprexa, Abilify, both Abilify and Zyprexa, both cariprazine and quetiapine. Interestingly, no one chose Vraylar or quetiapine alone. So the answer is C and D. Both cariprazine and quetiapine have FDA approval for both phases of the illness, but I will say that all of these medications in practice are often used for both phases. That's probably why there's some confusion. But the strongest evidence is for cariprazine and quetiapine, particularly for the bipolar depression phase of the illness. So antipsychotics in bipolar disorder, it can be used in the management of both acute episodes of both phases of the illness, as well as maintenance therapy. So when someone is euthymic and you're trying to prevent future episodes of both depression and mania. It tends to be used as second line for maintenance therapy because of all the risks associated with antipsychotics being used in the long term, including metabolic syndrome, tardive dyskinesia, et cetera. We tend to use mood stabilizers such as valproic acid or Depakote or lithium. Those are the 2 most common mood stabilizers, which I'm going to save for another talk. But there are cases where people can either tolerate the mood stabilizer, or they prefer an antipsychotic, or they want a long-acting injectable formulation. And so those are cases where we would choose to use antipsychotics for maintenance therapy. Generally, we prefer to use second-generation antipsychotics. They tend to have lower risk of EPS symptoms and tardive dyskinesia. Although in our population, we do use Haldol a bit, haloperidol as a long-acting injectable because it's far cheaper on the inpatient setting. And that's why you'll see a lot of folks leaving 7B started on Haldol because we, per our formulary restrictions, have to start people on Haldol before we can move on to something like Invega or Abilify Maintainer. So these are the most used second-generation antipsychotics. We have olanzapine, also known as Zyprexa, which is FDA approved in combination with fluoxetine, Prozac. And the brand name for that medication is Symbyax, but most people just prescribe these two alongside of each other to have more flexibility in the dosing of both medication. So that has the approval for bipolar depression only in combination. Risperidone or Risperdal, which really only has FDA approval for mania treatment. Abilify or aripiprazole, also only FDA approved for mania, but often used for the depressive phase of the illness. And quetiapine, which has approval for both mania and depression. So I'm going to go through each agent and just give you kind of like the nuts and bolts of how I think about selecting each agent and some of that kind of general dosing recommendation. So let's start with olanzapine. We know it really well. A lot of our patients get started on olanzapine, particularly when they come through psych emergency services, because it's the most sedating agent. And so it can help in periods of significant agitation. It has a pretty low risk of EPS, and it's helpful in stimulating appetite and promoting sleep. So if some folks are really manic and not sleeping and not eating, this can be a good agent to reach for in the acute phase. And as I mentioned, it's FDA approved for bipolar depression with Prozac. The downside, as in our case that I spoke to, is that it's very high risk for weight gain and metabolic syndrome if used chronically. And that weight gain happens within the first 3 months or so. So it's pretty early on. And it has an LAI, but we don't use it in practice because it requires it can cause respiratory suppression. It actually requires enrollment in a REMS program. It's just not really used in practice. So not really a realistic LAI option for this medication. So generally we start 5 milligrams at bedtime, although you may start 5 milligrams twice a day. And generally we go to a maximum dose of 30 milligrams. We do have cases where we go up to 40. We want to keep a close eye on folks' lipids, A1Cs, and their weight if you're losing it long-term. And there's lots of drug-drug interaction with a lot of our psychiatric medication. Olanzapine is cleared by CYP1A2. So ritonavir induces CYP1A2. So if you're using this in combination, you may actually need to increase the dose of your olanzapine. Next medication I'm going to talk about is risperidone. Risperidone is a great option because it's a really potent D2 blocker. So we say it's the most typical of the atypicals. It acts the most similarly to something like haloperidol. So if someone's like very psychotic, having hallucinations, I will often reach for risperidone. It has a generally lower risk of EPS, but of the second generation antipsychotics, I would say it's on the higher end of risk for EPS symptom. It has a long-acting injectable formulation, which is a really good option for folks that you're considering long-acting for. It tends to be slightly less sedating, so people tend to tolerate it a bit more. Downside is that it's a pretty potent alpha receptor blocker. So if you have folks who are older, more frail, lots of medical comorbidities, you have to think about fall risk in the population, and you may just need to adjust the dose accordingly. There's a risk of prolonging the QTC, and there's a risk of hyperprolactinemia and EPS. So the dose, generally I start 0.5 to 1 milligrams, either at bedtime or twice a day, depending on how frail someone might be. For older adults, I usually start like 0.25 at bedtime or 0.5 at bedtime. And then you want to monitor orthostatics really closely, QTC, EPS. The maximum dose is about 8 milligrams daily. There are cases where you go beyond that, but I don't see much benefit beyond 8 milligrams in my patient population. And you want to make sure you reduce the dose when you're administering with any protease inhibitors. And then for the long-acting injectable, there's a lot of options, actually. There's a monthly injection. There's options for a 3-month injection. There's actually now an option for an every 6-month injection, creatively called Hapira. And so for folks who really struggle with adherence, this is a great medication to reach for. It does not require an oral bridge. So you load the dose, and after the 2-part loading series, you can stop the oral medication. Abilify or aripiprazole, this is a really great option because it's effective in managing psychosis. It has a really low risk of QTC prolongation. There's some evidence that it might actually shorten the QTC in some population. And it has one of the lowest risks for metabolic syndrome amongst like kind of the older 2nd-generation antipsychotics. It has a long-acting formulation. The downside is that it can cause more impulsivity, which, is counterintuitive in some more folks with mania. So you have to watch out if their symptoms worsen. And it can take 1 to 2 weeks to reach steady state. So if you need something to work quickly and fast, this is not the medication to reach for. And as a result, it's not helpful as a PRM medication. Typically start 5 milligrams, and the titration is slower. So I make dose changes about every 5 to 7 days to a maximum dose of 30. Most folks end up on a dose of 20 to 30 milligrams or so. Monitor for akathisia or restlessness and impulsivity. And there's some dose adjustments needed for drug-drug interaction. There's initially a monthly long-acting injectable formulation and a 3-month injectable formulation. This does require a 2-week oral bridge overlap, so something to think about in selecting this long-acting. And then lastly, of the more commonly used 2nd-generation is quetiapine. This has a lot of benefits. It's sedating, so it can promote sleep. So folks are really struggling with insomnia, this is a good one to reach for. It is FDA approved for bipolar depression, probably one of our most reached for antipsychotics for bipolar depression, and has a very low risk of EPS. Actually, we use it in Parkinson's psychosis, so it's very low risk to cause the motor symptoms of Parkinsonism. Downside is that it's also an alpha receptor blocker, so it can lead to falls and orthostasis. There is a risk of metabolic syndrome. People can gain quite a bit of weight on this medication. At high doses, it's fairly anticholinergic, something to think about in the older adults, and it does not have a long-acting formulation. So you typically start at 50 milligrams daily. You can start lower. I just start 25 milligrams for my older adults. And then you increase by like 50 milligrams to 100 milligrams every 1 to 2 days, just watching closely for orthostasis. The packet insert does allow for you to start 300 milligrams at bedtime for people who are in an acute episode of mania. I feel uneasy mainly because I'm a geriatric psychiatrist and I'm worried about people falling down. So I don't do this, but I know a lot of folks in PES do this and have good results. You monitor for orthostasis and metabolic syndrome. And again, there's some drug-drug interaction to look out for. And so I'm going to switch gears a little bit, and I know this kind of rapid fire, and hopefully we can disseminate the slides after so you can have these as reference too. But these are some of the newer antipsychotics that I'll touch on briefly. The oldest of the newest one, I think, is lorazepam. It's been around for about 10 years now or so. And the newest is Lybalvi. So I'll quickly go through these, but I have a little less familiarity with these medications just because they're more expensive. And you have to fail multiple other antipsychotics to get approval for these medications. However, in the years to come, I think they're going to become more and more available to our patient population. So lorazepam, also known as Latuda, is a great option for bipolar depression. It's really only FDA approved for bipolar depression. It's not effective for mania. So if you have someone who cycles through a lot of manic episodes, it's not going to be a good maintenance medication. It's also FDA approved for schizophrenia. So you can use it in that population for psychosis, not for mood stabilization. Cariprazine is also known as Vraylar. It's FDA approved for both bipolar depression and mania. And its claim to fame is that it does not cause metabolic syndrome. It's very similar in mechanism to Abilify. So it's a great option if people are struggling with weight gain. And the last one is Lybalvi, which is a combination of olanzapine and samidorphan, which is an opioid antagonist. And that combination with samidorphan basically causes less weight gain with initiation of olanzapine. However, it is notable that while it causes less weight gain in their initial RCT, it did not change any of the parameters around metabolic syndrome, so no changes to lipids or A1C. There's some argument that the trial wasn't done long enough to see like kind of the end results of long-term use of olanzapine. I'm going to quickly fly through the dosing guide, so I want to leave time for questions. So lorazepam, you start at 20 milligrams as a starting dose. It's very important that people take it with food. So if people don't have consistent access to food or they have low appetite, this is not the medication to reach for because you need at least 350 calories to absorb the medication to the gut. You can increase by 20 milligrams every 2 to 5 days, and the maximum dose is 120 milligrams. There is some risk of metabolic syndrome, akathisia, and EPS. Again, there's drug-drug interaction, which is kind of a theme of the talk. Always make sure that you're checking your drug interaction calculator, whichever one you use when you're starting any antipsychotic. And again, there's stronger evidence for bipolar depression. Cariprazine, you start at 1.5 milligrams. It's a pretty narrow dose range. It goes from 1.5 milligrams to 6 milligrams in 1.5 milligram increments because they're capsules. There is some evidence for going up to 12 milligrams, but the cap is usually 6 because it can cause quite a bit of akathisia or restlessness. And this is the most common reason why people stop this medication. However, it's very low risk for metabolic syndrome and QTC prolongation. And then lastly, Lybalvi, which is like the newest option that we have to reach for. The challenge with this medication, it only comes in combination pills, so 5 and 10 milligrams. And so you can only increase in 5 milligram increments, and the maximum dose is 20 milligrams in this combination pill. It's very expensive. It's $65 a tablet, so a monthly supply is going to run up quite a price tag, but there's hopes that down the road that this will become more affordable. I'm going to quickly run through the case and I'm going to take some questions. So we discussed, switching antipsychotics, and he actually really wanted an option with a long-acting formulation because he was already taking a lot of pills by mouth and he just did not want another daily medication. So he was cross-tapered to Abilify over a period of a month and then later started on Abilify Maintainer. And he actually noticed that he lost weight in combination with improving his diet and exercise, and he didn't have any further episodes of mania. So in summary, antipsychotics have a role in management of both bipolar depression and mania in both the acute phase and the maintenance phase. We have some newer antipsychotic formulations that are really focusing on weight gain as an indication. And selecting antipsychotics, there's not one best antipsychotic for the management of mania. We really want to focus on which side effects do you either want to avoid or exploit in particular patient population. So thank you. I know a little bit of a whirlwind, and I have references in the slide. I'll make sure I'll share slides after the talk.
Thank you so much, Bill. That was great. I'm online, but any questions for Dr. Smith? I'll walk around. I'll start with one. As you were talking about the long-acting formulation of risperidone in particular, is there a way that you think of the side effect profile as different for the long-acting formulations, either risperidone to paliperidone or for aripiprazole? Are you more worried about QTC prolongation, sedation, et cetera, or is it similar to oral formulation?
It's pretty similar. You do want to make sure that they tolerate the oral medication for a good while. There's some folks that suggest that the long-acting doesn't have as much of a peak trough phenomenon, and so some of the side effects may be a little lesser with the long-acting formulation, but I have been in some scenarios. There's one case I had a woman getting neuroleptic malignant syndrome because she was only on risperidone for like a week, then started on Invega, and then got NMS, and then she had to be in the hospital for a month because the medication was in her system for a month. So that's an extreme example, but you really want to make sure someone tolerates the oral before you switch to the long-acting.
Great. Thank you.
Can you speak more to that? That was my question, which is that a lot of folks just have trouble. You have trouble getting them stabilized. So what do you need to see that they've taken for you to feel like they can go to injectable? Like, what's your threshold for direct to inject? If they've tolerated other meds in the past, because I have folks where if they could take a pill every day, then we wouldn't be in this place. And and have really struggled with what's safe to do, but your story makes me worried.
Yeah, and that's an extreme example. There are some providers who, like, after 3-4 days, regardless of the NMS risks, the risk of prolonged psychosis and mania outweighs the real risk of NMS, so they're quicker to inject. I have the luxury of working on inpatient psych, so I can keep people in the hospital for a little bit to see them stabilize. So I usually wait about a week to 2 weeks before I reach for long actin in my practice. I know if they tolerated it before for extended period, they might be quicker to reach for the long acting. No, well, it depends on the formulation, because if it's risperidone, we have to worry about that alpha receptor blockade. So if you go direct to an inject with a therapeutic dose of paliperidone, you make people fall down. So there are cases, particularly for paliperidone, that you do want to make sure you have someone stabilize on a dose before you give them a long actin. But for something like haloperidol, doesn't really have that, like, that period where you need to make sure that they stabilize in terms of their blood pressure. And so you could probably go to inject much more quickly. Same with the Abilify. So I would say typically for paliperidone, you might want to wait a little bit longer.
And phone a psychiatry friend.
Yeah, and you can always reach out. I don't mind being emailed on a curbside about any cases. So I think you'll have my email. Please reach out if you want to run a case by me.
Great. And then last question for you, Dr. Smith from online. I have seen a couple of patients on, apologies for the pronunciation here, lamatoperidone. Where does this med fit in? Sorry, I can't say.
Yeah, that's a great question. I honestly have not really explored using this medication at all. The data is very new, so I think time will tell. But maybe I can think about that for the next talk I give and hopefully have an update for you all.
Thank you.
You can dose it with ritonavir, which is one of the nice things. You can dose it with ritonavir, which is one of the nice things with lumateperone, but it's also in the family of cariprazine, where there's like more D2, D3, and you don't get the extrapyramidal symptoms with it. So it's friendly, but it's brand new and harder to get, and we don't know as much about it as other ones, but it exists.
Yeah, hard for our patient population with our formulary restriction. Thank you, Pierre.
Wonderful. Thank you so much, Dr.
Thank
Smith.
you.
Hello, good morning. I'm so excited to be here and actually to talk about a totally non-controversial topic about managing ADHD with concomitant stimulant use disorder. So hopefully we'll go on this journey together and we'll all walk out friends. All right, I have no disclosures at all for this talk. We're going to talk a little bit about diagnosing ADHD in the context of stimulant use, which is really hard. And we're going to talk about a little trauma-informed strategy of how to do it, or at least how I do it, and talk about why. Going to start off with a little case to kind of frame what we're talking about, because that's how you start talks. We have a 40-year-old cis gay man who has been injecting and smoking 1 gram of meth every day for 5 years. They have a history of ADHD, which was successfully treated in the past with methylphenidate, but their stimulants were stopped when they disclosed to the provider they were smoking meth. They want to stop using meth, but they've been struggling due to the cravings and worsening of ADHD symptoms when they do try and stop. What is the next best step? What would you do? Would you offer them mirtazapine and have them stop meth for a year and then start treating their ADHD? Would you start them on lisdexamfetamine at the high dose in the morning and provide support around cutting down their meth use? Would you refer them to behavioral therapy to help manage their cravings? Or would you refer to neuropsych testing to reconfirm their ADHD diagnosis? Like, what would you do? And no Jeopardy music going, right? I don't know. It's like, oh no, we all good? I don't know. How long do we give them? Is everyone locked in? Don't we get locked in an answer? I don't know. We'll see where we're at. Sweet. Awesome. So it's a little bit split up here. You know, so we have some folks who want to do mirtazapine, some folks who want to do the lisdexamfetamine, and some folks who are referring to behavioral health. My correct answer is going to be to start the lisdexamfetamine 70, and this is going to be my argument as to why. So ADHD is very common. Depending on the estimates, you'll hear anywhere from 5 to 15% of adults have ADHD. It's probably closer to 5, but in the estimates, that's around where it's at. Inattention symptoms are very common and associated with multiple different mental health issues. And a lot of people can feel that they have ADHD. It's one of those DSM things when you read up into it, you're like, I have that, I have that, I have that, and you'll self-diagnose. And what I thought was interesting, there was a study that looked at 260 students who thought they have ADHD, ended up going for an evaluation, and only 5% of them actually met the DSM criteria. So it's more to say like a self-report of ADHD doesn't like have a whole lot of weight to it. It can be real, but we all feel like we have it because, we have inattention so common. The main difference is, though, ADHD is a neurodevelopmental disease. That means it is something that starts as a child. There should be some symptoms that appeared up when you were younger, but the big caveat with that is that some children are often missed, especially girls, boys tend to have more of the hyperactive symptoms, and so they get pulled out of class because they're acting up. Girls tend to have like more of the inattentive symptoms, so they can easily be sort of missed during earlier screenings. And sometimes the stresses of childhood are a little easier to cope with. And then when they become an adult, those stressors are harder, and then the ADHD symptoms pop up. But the key here with ADHD is that their inattention is not related to mood swings, and it's present in multiple different settings. And if you go through the DSM, you'll find all these little check boxes about like forgetting things. Like we all forget things. I find the DSM criteria for it is hard to apply to patients. So when I'm having my clinical interview with them, I'm asking about life examples. I want to know, like, can you pay your bills on time? A key thing is like oftentimes people with ADHD have all their bills on auto pay. Are they involved in multiple car accidents? We know that people with ADHD have more car accidents than people who don't. Are they turning in assignments late? Did they not pay their taxes? A great one is like, do people think you're lazy? Because oftentimes people who have ADHD are just seen as lazy people. And so this finding out what the behavior was versus just asking like, do you have poor listening skills? Like, those kinds of things are just not as specific for folks. And when you treat ADHD, that ADHD stimulant is going to calm the mind and calm sort of these racing thoughts that people have. Now, the difference with regular inattention, we all have it, right? Since y'all been here, y'all haven't been focusing on this talk the whole time. You're probably thinking about someone else right now. We all have some level of inattention, and that's normal. Like if I sit you down to read the encyclopedia, you're going to be like, oh, I can't read this. This is like too hard to read the encyclopedia. Like, yeah, that makes sense, So that level of inattention is normal. But things like depression, anxiety, and bipolar disorders all have inattention as part of them, and as well as like substance use, in particular cannabis. Cannabis is really bad for like your attention, your focus, and your cognition. So if you're like the wake and bake kind of person, you're going to think that you have ADHD. You might still have it, but like the cannabis is not making that any better. And the big difference here is that your mood disorder, if you improve your mood disorder, your inattention is going to improve. If you give someone who has inattention or like they have like a generalized anxiety disorder and they have inattention and you give them a stimulant, that's going to ramp up their anxiety. Stimulants worsen anxiety and they're going to feel like they have more energy and they might feel better, right? Everyone feels better on the stimulant, but it's not going to like calm their mind and focus their mind. They'll still have all these racing thoughts. And just a little side note about adult onset ADHD. A lot of people talk about this. There's really no evidence to support the existence of adult onset ADHD. By definition, it's a neurodevelopmental disorder. So it's supposed to happen as a kid. But oftentimes, as I mentioned before, like, it's missed its screening for children. We just didn't find out that they had an issue or they coped very well. Or like if you're in the South, like you just got slapped, right? And so we didn't really have good screenings for me sort of growing up. And then, oftentimes we don't look at other mental health conditions. There's like a big one like cyclothymic temperament. It's on this like bipolar spectrum disorder where people have like, they don't quite meet like, hypomanic episodes or full depression episodes. They're kind of up and down, bouncing kind of every day, feeling really good, feeling depressed. And those temperaments also have a lot of inattention for them. And those folks won't respond to a stimulant. They would need like a mood stabilizer or something else like that in order to improve their symptoms. So we don't really see a thing where you had absolutely zero issues at all of ADHD and all of a sudden you hit 40 and then you have this ADHD thing pop up. So as of now, that's not really a thing. And I always like to remind that ADHD is like a real disease. I think oftentimes we look at it as like, oh, it's just some college student who needs to like study better or something. This actually has real world consequences for people. We know that this haphazard focus that people have, they have more car accidents, more injuries, falls, they have poor time management. It makes it harder for them to work, harder for them to have career growth and be successful in their roles. Financial stressors from like not paying bills on time and being late with things, self-treating with substances, poor self-image, often seems like I'm lazy. They put a lot of it on themselves, and legal issues from some of the impulsivity that comes with ADHD. And overall, this was some new data that came out where people with ADHD had a 13-year decrease in life expectancy. They're 2 to 4 times more likely to have Parkinson's disease, and then there's an increased risk of dementia. So this is not just like a student needing to study at night kind of illness. It is like a severe illness for a lot of folks, and we need to keep that in mind when we're talking about this. So what's the link with ADHD and stimulant use? There is a bit of a link for people who have ADHD and who use stimulants. This was a little study where they looked at people with a meth use disorder and screened them for ADHD. And they found about 70% of people who were using meth had screened positive for ADHD. This was a screening tool, so it doesn't really mean there's a diagnosis, but there is a strong link in people who are using meth and ADHD. We know that people who have ADHD had higher rates of meth use in the last 30 days in this study. So they are linked on some level and go together. Now the question comes up like, how do you treat and what to do? Old school psychiatry will teach you to take someone who has ADHD and stimulant disorder, use disorder, and treat the mood use disorder first, and treat the stimulant use disorder first, and then like wait a year or whatever, and then start sort of treatment. This was a study of folks who were in an outpatient treatment center. This was for like all substances. It wasn't like meth. I wish I had broken down a little bit better, but there's people who are using cocaine. And what they did here is they took people who are going into these residential treatment programs and screened them and treated the people with ADHD. And you can see here in the blue line, the people who got treated for ADHD had a much higher retention, almost 2 years out after that program, to stay in that residential program. So it's like 70% of them sort of stayed in, versus the people who were not treated and didn't get the ADHD medications, that number dropped down to like 35% or so. So treating people aggressively with ADHD first will improve retention and care for substance use disorders. And I think this really just calls into question this like traditional psychiatry model we have of like waiting to treat ADHD for people who are using stimulants or substances. Like, is that really wise? Like, how much are we impairing their recovery by not taking their ADHD more seriously and taking care of that first? And then this was another study that looked at people who were incarcerated and they had ADHD, and they were started on high doses of methylphenidate about 2 weeks before they were being released, and then they were randomized to placebo. And so they treated their ADHD and measured urine drug screens after they were sort of released. And you can see here, like at 24 weeks out, the people who had their ADHD treated had a higher proportion of negative urine drug screens at 24 weeks. They also stayed in care longer as well. So treating ADHD first does improve people's use of stimulants as well as retention into care. There are a couple of treatment options for ADHD. You can kind of break them up into groups. You have the amphetamines, which are two main ones that you want to focus on using are like the mixed amphetamine salts, the extended release versions, and the lisdexamphetamine, which tends to be my more favorite. And then there are methylphenidates and then non-stimulant options. So in adults, the amphetamines work the best, but the trade-off is that they have more side effects. Methylphenidate's the nice little middle of the road where you get really good effects and like fewer side effects for folks. And in adults, the non-stimulant options don't quite work as well, but they're great options for the right person. They work really great in kids. Like non-stimulant options are like probably the way to go. But when it comes to adults, using more of the amphetamine-based will get you a much higher efficacy. But it's important to note that there are a lot of side effects that can come with these, like, the amphetamines, a lot of anxiety, cause palpitations. I've seen psychosis develop on people on the lisdexamphetamine, and these can also trigger mania. So if there was an underlying bipolar disorder that you didn't pick up on or that you didn't know, and you put them on a stimulant, it can trigger manic episodes for folks. But the lisdexamphetamine is a great first option for adults, just because of the way it's formulated, which we'll get into. Methylphenidate extended release is like a better option if there's a lot of side effects you're worried about. It's also less likely to cause mania. It's a safer one if you were trying to treat someone who had bipolar disorder, though they should be on a mood stabilizer if you do that. And then the non-stimulant options, particularly for people who are using meth, it's not something I would use, but they can serve as nice adjunctive treatments to the other medications if you wanted to use them. So, but the extended release formulations are always the way to go because they're less likely to be misused and abused, and they kind of work better. So this is just two graphs just to kind of get a little idea of how these drugs kind of flow in your system. The one on the left is for the mixed amphetamine salts, the Adderalls. And you can see the little line, the little circle is the extended release one. And you can see it goes up nice and gradual and then kind of comes down nice and gradual. It's nice and smooth. If you use the instant release versions, that's the one, the little triangle you can see on the left, it kind of goes up a little bit and then you get this afternoon crash. And then you expect someone with ADHD to like remember to take their second pill. And so then they do take it and they're going to go back up. So this crashing and going back up gives this roller coaster throughout the day. It's also more rewarding and higher risk of like misusing when you do these instant release sort of versions and you don't get this nice smooth effect from it. And then on the right is lisdexamfetamine. That's a special formulation of Adderall. It's actually the dexamphetamine part of the Adderall. So Adderall has like two components, two drugs to it, and they just take the dexamphetamine part, which is the more potent one, and put it in this novel sort of drug releasing system where you have this lysine thing that happens, but it ends up being this nice smooth, going up of the drug and nice smooth kind of going down. So you get a nice effective treatment of ADHD, but none of the rushes that you can get from using the instant release stuff. Now, the big question comes up is like, Pierre, if you're giving someone a stimulant who's like using meth, are you not going to like just like destroy their cardiovascular risk and like cause problems? And this is my argument. Why not? There is no data. There was never a study that looked at people who had meth, like did they get like Adderall and did it do anything? But for this like rational comparison I'm about to make, I would like to remind people like methamphetamine is a prescription drug. You can prescribe it. It can be used for ADHD. I would have no idea what would happen if you actually did it, but you can pull it up on GoodRx and it exists. And prescription meth, kind of gets dosed up to 25 milligrams. So that's the part I want y'all to think about when we're talking about how much more risk we're adding to folks who are using meth. So when you look at someone who's smoking like a gram of meth, the risk of cardiovascular disease is around 32%. That is a lot, and here you are and say, hey, I want to end up treating this ADHD with this oral medication. And if you add in 25 milligrams of like oral meth, which you're going to absorb a tiny amount, 25 milligrams compared to 1 gram is tiny. It's a little drop in a bucket. ADHD meds do have a risk of cardiovascular disease. It's about a 4% increase each year. But my argument here is that if someone's like smoking a gram of meth, the tiny amount of drug that I'm going to be adding as part of this is not going to worsen it. And then the goal of this is not that they're using meth every day and taking this every day. There is a bit of overlap where that can happen. The goal here is just to be like, hey, it's okay if this happens for in the beginning, where we're not going to be worsening your cardiovascular outcomes by adding in this dose of stimulant if you're already smoking a gram of meth. And then another question kind of comes up of like, how high can you go on these doses? There was this one cool study looking at lisdexamfetamine where they went doses as high as 250. The max dose is 70. So they really, really sort of pushed it up. And there was 16 participants. It was open label, non-randomized. And that dose was generally well tolerated. It didn't have any significant adverse events, including cardiovascular events. It was underpowered for like looking at meth use, but in here at that 250 milligram dose, you can see it went from like, days of use in the past, 28 days, they were using about 21 days, and it did cut their meth use down significantly, not down to 0 though. And I think this sort of comes up a lot sometimes with patients who think like, oh, if I just had a higher dose, would it sort of alleviate things? Here going up to 250, it still wasn't like perfect at completely cutting out the meth use and meth cravings. Like methadone's great because that you can kind of match up opioids. You can go up really sort of high on it and like help people get a lot of relief from opioid use disorder. But in stimulant use, it doesn't seem like you can really quite do the same. It has a huge impact. And in an addiction world, people would go crazy over this data. You're like, oh my God, it's so much lower. But it's not this like 0 that I think a lot of people hope to have or would like to see when people are using stimulants that you treat it and then it stops right away. But it did decrease and you can go up high, at least safe in this one study. The conflicting evidence though for that is that in general, like the max dose, at least for like Adderall, the amphetamines, is 60. The FDA max dose is 40, but in the studies that brought like Adderall out to market, they studied up to 60. And so 60 is kind of considered safe, even though the FDA approval is for 40. There were animal studies that looked at higher than 60 milligrams of Adderall, and it did cause damage to the dopamine terminals. So I'm not quite sure why, like with the lisdexamfetamine, that was so different. But in general, like 60 milligrams is considered the max dose to give to folks. And at higher doses of the Adderalls, people get psychosis, substance use, and psychiatric hospitalizations if you push it too high. And the highest dose of lisdex is 70. And those are really the max doses that I would adhere to. And then sort of comes up about the legality of doing this. And it's kind of hard because we're in California. ASAM came out with this great little stimulant use guide, and they, according to them, thought it was okay to use stimulants to treat a stimulant use disorder. So this is independent of ADHD. California has a little more restrictive laws around it. And the interpretation of the laws in California is that for folks who don't have ADHD, is that you could do it for 30 days, but then after 30 days, you need to have an FDA approved maintenance treatment after that. So that's all to say, if you do this and you do it in California, you're not treating stimulant use disorder with this, you're treating their ADHD, and your plans should be about the ADHD, and any dose changes should be about the ADHD, and any stimulant benefit you get is sort of a side note to that. And so this is what I do in clinic. And just want to, this is not like a research study. This is just kind of how I handle these situations. So one, I make sure that the patient meets criteria for ADHD through a clinical interview. You don't need to do neuropsych testing for ADHD. Neuropsych testing is actually not that great for ADHD. It can often be incorrect. A lot of screening tools we use for ADHD are also not great. There is like this one tool called the Diva, which is a nice extended structured interview that people can do that has a lot of promise for accurately diagnosing ADHD. But at the end of the day, it's the clinical interview is all you need to have this diagnosis, and documenting those applied life experiences of like does not pay bills or missing bills or all these little things to match up to the criteria in the DSM to get that ADHD diagnosis. They have to be willing to cut down or stop their stimulant use. As I started explaining to people, like meth is actually indicated for ADHD. Like if they wanted to treat their ADHD on meth, they could just use a whole lot less of what they're actually buying on the street and swallow it instead of injecting it and actually treat their ADHD. So if they're not wanting to stop, there's no real point in doing this. If they're not in that area or that mindset, they're just still very pre-contemplative about it. Because the goal is not to like just give them stimulants and have them continue on meth. The goal is to give them stimulants as a bridge to get off the meth. And then they also have to be wanting to cut down their cannabis use. This is mostly because in the studies we've seen that like if you smoke daily cannabis, there is no dose of amphetamine that is going to treat your ADHD. So basically daily cannabis use counteracts all the effects that you're going to get. You can crank up your amphetamine as high as you want, but you're not going to see any improved outcomes. So if you're smoking like meth every day and smoking pot every day, like doing this treatment is just not going to work. You have to be able to like cut down a little bit and create a little space for these stimulants to work and to improve your ADHD in that space. They have to have a safe place to keep their medications because we don't want to have these stolen. They're like, you can sell these college markets, all that. So we want to make sure there's a safe place to keep things. They have to be able to come and attend visits weekly. So we keep a very close eye on them. They can be offered additional treatments, contingency management, mirtazapine, or like bupropion, naltrexone, but it's not required. I appreciate contingency management for it, but oftentimes the folks, at least that I take care of, have gone through it a million times. And if I hear like contingency management again, I just want to scream. I'm like, it's like, it's great for like first line, second line, but if someone's been doing it for 5 years, I'm like, it's not like the thing to do. So I don't make these as a requirement. Mirtazapine, bupropion, they're all kind of great in concept, but if you did it and you failed it, it's not like I feel like you have to be on it in order to access this. But if you are going to do something like bupropion is one of the non-stimulant options for ADHD. So it's a great little one to pick as an add-on therapy to help with ADHD symptoms. And then what I do is split up into weeks. So week 1 and week 2, we do weekly fills. I just start off at the highest dose and just go for it. Because if you're already using meth, I don't need to start you off on a low dose and titrate you up. We're just going to go hit you as hard as possible because that's probably what you're going to end up needing. And we do weekly phone calls and weekly in-person check-ins. And the first 2 weeks, I'm like, I don't care what happens. You can do whatever you want. You're just starting off on this. There doesn't need to be a change in meth use. If there is, it's great. If there's not, it's fine. By weeks 3 and 4, we still do weekly fills of the lisdexamfetamine, and we do the weekly phone calls. But the meth use needs to start decreasing in some kind of shape or fashion or something. Something just needs to change. If it's been a month and you've been on this highest dose of lisdexamfetamine and nothing has changed, we just need to stop and say, hey, is this the right time to be doing this? Do we need to rethink what we're doing? Because not one thing has changed. And then after a month, if something's changed, you just smoking less or whatever it is, or you went from injecting to smoking, something went better. I switched to 2 weeks, and then we do 2-week fills of the maximum of the dexamphetamine. And at that point, hopefully they're using a little less, and you can start assessing more improvements in ADHD symptoms. But the meth use needs to be decreasing for that second month as well. And then by week 9, the meth use should be, at least we want it to be in a spot where you have a little more control over it. It doesn't mean that you have to be completely have stopped it, but we schedule a planned urine drug screen. So this means there's not a surprise. And then during this whole time, I'm not here to be like, I got you, use meth or anything, but we pick a date that someone feels comfortable with for them to come in and do a drug screen. You want at least a week or so. Sometimes when people are using heavy, sometimes it's over a week I've seen, but generally a week for this meth to get out of your system and have a negative urine drug screen. So it's planned out. And the goal is to see, do they have enough control over their meth use to be able to stop it for a week? Because that would be huge, right? That ends up being, a good indicator that they're getting control over their substance use. And if they're not able to stop for a week after those 9 weeks, you reassess this plan. Do we need, is this still a good plan to keep going? Or if they have a negative urine screen, then we can kind of continue doing monthly follow-ups and keep providing support for folks. And so part of this, and this is part of my journey, in studying addiction medicine and doing all this stuff in psych where things don't work properly, is trying to define what success looks like. So that first case that you had is actually a real person who I take care of. And it's been about 1.5 years that he started doing this. And he went from, smoking and injecting 1 gram of meth a day and not working. And now he's smokes residue in his pipe. So he doesn't smoke the whole thing. He smokes here and there. And in part, his meth use is tied to sex so much for him. He's on this journey of understanding sober sex, but he's able to provide a negative urine whenever I ask for it. And he's actually back in school and doing school in person for him, which is very unusual. So he's in school, he's in person, he still smokes 3 times a week, but he's able to succeed in school. And he's able to have control over his use to where he stops. It's not perfect, but it's in a better spot than where he was to begin with. And so I think part of this is just finding what is success when we're trying to help folks. So yeah, and any questions, and how do we keep this going at Ward 86? So, yeah.
A clap for you.
Yeah.
Turn on the microphone. What questions do people have for lots of them? Great. I'll start.
Hey, thank you for that talk. Are there any legal issues to prescribing to what you just described with the treatment of ADHD and prescribing method?
So as long as you document the ADHD, so you document out of the ADHD, people get access to stimulants. That's the primary treatment for folks. So as long as in there you have everything documented, you have a solid case for this diagnosis, you treat, and then the stimulant use can be secondary. You don't get in trouble for the fact that they use meth. But if you are documenting towards the stimulant use disorder and saying, hey, they're still having cravings, I'm going to increase this dose to 60 milligrams to manage stimulant use cravings, you can only do that for 30 days. And then after 30 days, you're not allowed to do that because it has to be an FDA approved treatment. So as long as you're documenting towards the ADHD and treating the ADHD, the rest of it doesn't matter. So, yeah.
Thanks, Pierre. This was a great talk. I learned a lot. I appreciate what you said about studies showing that if you're using cannabis daily, this is not going to probably be effective for treatment of ADHD. Yeah. What about other substances that a patient might be using, GHB, alcohol, opioids? Would those also increase inattention and then therefore expect to have a lower effective treatment for ADHD?
I haven't seen a study on data looking at that. I mean, there's definitely lots of studies on cannabis and impacting ADHD. I haven't seen anything on opioids impacting ADHD. It would make sense that it would on some level, but I haven't seen anything that was as direct. The cannabis studies are it directly doesn't change. No matter what you do, you can't counteract the effects of it. But I imagine it would on some level, but yeah, I don't know as directly. Yeah.
Great.
I don't know if you happen to know.
We have a question from the chat. You're mentioning that patients may cut down on stimulant use, but if at 9 weeks someone is not able to stop using for 7 days, do you consider stopping your prescribed stimulants for ADHD?
Yeah, so part of it is, I think sometimes they might be like a little alert to like, hey, I'm not able to stop, and they might be willing to try it again. But it's more to say you need to have a conversation at that point in time. Don't keep doing what you've been doing. It's obviously not working. If you're using meth every day, meth treats ADHD, right? So like giving you 70 Vyvanse is not going to be doing anything. So it's a conversation like, is this getting the outcomes that we want? And it might be that like he's stopping for 5 days and is testing positive on the urine. And then I'd be like, hey, I'll keep working with you to make this sort of happen. But it's just a marker to have a conversation, because the idea is that you don't just keep doing this if they're not able to like stop meth at some point. They have to be progressing. The idea behind this is to help them gain control over their substance use. And if it's not doing that, then like, what are we doing? And I think we see that in those high doses of like the dexamphetamine, that even at 250, a lot of folks were still using. And would I keep someone on 250? I don't know if I would continue that. And like, that's not the outcome that we're looking for. So, yeah.
Great talk. It's a great topic. I have a question about folks who have meth-induced psychosis or a history of that.
Yeah.
How do you approach starting stimulants, knowing that stimulants are much less potent?
Yeah.
How do you consider that?
Well, I think one, I'd make sure that if it's a stimulant-induced psychosis kind of situation, you could end up opting in doing more of the methylphenidate route. And in some of the earlier studies, they did look at methylphenidate. In my personal experience, the methylphenidate just hasn't been cutting it when I've sort of been doing it. But if you had like stimulant-induced psychosis, I would probably do methylphenidate instead of an Adderall-based drug, just to see how that goes. So, yeah.
Just on a practical level, and I don't know if anyone here from Bridge or HAP can comment, is Bridge able to do this? Because I'm struck by how this is a pretty time intensive and you're keeping a pretty close contact with folks, weekly, which may be outside what a lot of primary care folks can do. Will Bridge prescribe the amphetamines and do this management?
I think as far as I know, I'm the only person doing this. So
I think it's a great question. I think that the step that addiction medicine providers are not trained in is a diagnosis of ADHD that Pierre mentioned. And so we have been relying on our psychiatry colleagues to help us with that piece. And this is not something that's currently part of Bridge or HAP standard protocol. I think a question for Pierre about this is, I know you're leaving soon, but I think something that I think would all love more support with in general is like having more psychiatry embedded at Ward 86 and, in all of our clinics. And I'm curious how much time this has taken you and sort of what staffing power you would ideally envision for this sort of protocol.
Yeah, it does take a lot of time, but this is also something I'm passionate about and giving people a chance, right? And so, because doing an hour phone call every week can be a lot. I know for me, things that would help is like if we had like a coordinator, because I don't feel like a provider necessarily needs to check in every week. In this model, you could do like every 2 weeks to 4 weeks to actually have a medical assessment, but having someone to check in and help them with the MI and talking about how their relationship with their substance use is going would be very helpful. So having coordinators to help do those calls every week. I was sort of fortunate where I had some other time where I could take these calls. I wasn't doing these during my Friday clinic time. I would do it like during the week. And these were like quick half-hour, 10-hour calls. You develop a really close relationship with these folks because oftentimes like they've had the door shut in their face so many times and you're the first person to be like, hey, I'm going to hook you up and help you out with this. And so like you get this very casual kind of like conversation where like we would like text each other and like, hey, we can chat now. And like it made it easier to do that. So it was less structured, but I was in a position where I could do that. But you would need a coordinator to help with these things, because it is very time intensive to do if you're a solo provider kind of doing this on your own. So I would love to see like a substance use coordinator on the clinic to help with these calls and coordinate and helping with like any lost to follow-up issues or anything else like that. So yeah.
Thank you so much. Any other questions in person? I'll note that the Dr. Lum put a really wonderful article in the chat or the Q&A section of our Zoom about that Dr. Soon, Leslie Soon here at SFGH first author that's entitled Prescribing Psychostimulants for the Treatment of Stimulant Use Disorder, which again is related to this topic, but as Pierre mentioned, had that one slide on this, navigating some of the legal landscape federally. So I'm happy for those of you in person, if any of you are interested in that, I'm happy to send it to you all. I will say it's 9:30, so we'll close. Let's give a round of applause to these two fabulous speakers and thank you both.